I'm going to start by setting the context for today's discussion, and especially because the health inequities experienced by gay men are only starting to be recognized and interrogated. I think it's important to consider the state of the art in terms of understanding and responding to health inequities. So the problem, as many of us see it at the moment, is that there's a growing sense that current approaches to understanding health inequities are insufficient for increasing the understanding of multifactorial and multi-level complexities of health disparities and for identifying the most effective strategies to reduce them in the real world. Why is this? Well, traditional approaches tend to fragment vulnerabilities into distinct categories such as sex, gender, race, ethnicity, socioeconomic status, sexuality, geography, or disease status. They tend to prioritize one category over another, lump people into static and homogeneous groupings, i.e. men and women, and they fail to fully consider and analyze the context and influence of social power inequities. Now, an important exception to some of these traditional approaches has been the usage of a social determinants framework for understanding health inequities. And as I will try to demonstrate, intersectionality does share some similarities with this approach, but arguably expands on it to capture complexities and divergencies and within-group similarities. So as many of you know, Canada has played a real leadership role in the field of health determinants. PHAC has recognized the following determinants of health. I'm not going to go into them in any detail, but I think what is important to note is that more recently the discourse around determinants has increased, and the WHO has recognized that the determinants of health, that is, the conditions in which people are born, grow, live, work, and age, including the healthcare system, are mostly responsible for health inequities internationally, and it's only through action on social determinants that the lives, in particular health of the world's citizens, can be improved. So, the social determinants approach and intersectionality both recognize the multiple dynamic factors that influence the lives of individuals and the need to better understand and respond to these and working towards the elimination of inequalities. But where social determinants falls short is in its finite number of categories, that is, finite number of determinants that are listed, the lack of attention to the relationship among determinants, the lack of understanding of the wider context of structural inequities in which determinants are embedded, and insufficient attention to power. And this is the launch pad then for intersectionality. Now, don't let this scare you, this long definition, complex definition. I'm going to give it to you in plain terms in just a second. But intersectionality is concerned with simultaneous intersections between different aspects of social difference and identity. For example, is related to meanings of race, ethnicity, indigeneity, gender, class, sexuality, geography, age, disability, ability, migration status, religion, among others, and also different forms of systemic oppression, such as racism, classism, sexism, ableism, homophobia, at both macro and micro levels in ways that are complex, interdependent, and reflect intersecting systems of power relationships. So that's a real mouthful. How do we put this very simply? Health inequities are never the result of singular, distinct, explanatory factors, but the outcomes of intersections of different social locations, power relations, and experiences. And folks have tried to come up with a number of different metaphors to show what intersectionality really means, and the one that I've provided you here with is a traffic intersection. So what intersectionality tries to get at is what is at the intersection of all those crossings of roads, rather than focusing on any one road on its own. Now, intersectionality is a new and developing area of inquiry insofar as original innovative conceptual frameworks theoretical approaches and case studies are only starting to emerge probably in the last decade or so. But I think it's also really important to keep in mind that this is not really altogether new. Intersectionality has a rich history in social struggles and writings by feminists of color, in particular in the United States, who were increasingly critical of the second wave of the women's movement for representing only white, able-bodied, middle-class women and excluding and marginalizing others. But it has to date had a number of areas of influence in women's health, men's health, Aboriginal health, immigrant health, in understanding HIV/AIDS, mental health, dementia, violence, cardiovascular disease, diabetes, and obesity. What intersectionality does is it moves beyond the single or favored category of analysis that we often hear about, such as gender or race or socioeconomic status or class or sex, to really think about the interactions between different aspects of social identity and the processes of oppression and domination. So what intersectionality says is that the experiences of race and class and gender and sexuality and geography and immigration status and ability, among others, intersect to produce social locations and experiences that are equal to more than just the sum of its parts. And any individual experience means that different forms of privilege and subordination is dependent on race, class, gender, sexuality, and ability, that these things are interacting, interlocking, and simultaneously and mutually reinforcing. Now, having said all of that, and having talked to you about the influence that intersectionality has on the understanding of various aspects of health and disease and illness, it's important to understand that there are shortcomings within this paradigm, especially in terms of how it's dealt with issues of sexuality. Most of the research that's come out of the intersectionality field has focused on what we refer to as the holy trinity of gender, race, and class, to the exclusion of other social locations and experiences. So sexuality is often tagged on to be included as a difference that can be added to an analysis, but is rare. That actually rarely happens when we look at the way in research policy and services are approached from an intersectionality lens. So to quickly recap, according to intersectionality, social categories are dynamic, socially constructed. No one category of social identity is necessarily more important than any other, so there's no hierarchy that we can establish. Each health issue, problem, or challenge under investigation may require the consideration of a different constellation of factors every time, so one does not go into a research project or a policy intervention or an evaluation of service assuming that the same constellation of categories will hold in all places and all times. There's no a priori establishment of what is important and what is not. So what is the appeal? Intersectionality probes beneath single identities to reveal other factors that may be present and contributing to a situation of disadvantage. The key is the focus on the interaction, not just adding or layering additional considerations. It highlights the complexity and multifaceted nature of human lives at the micro, at the meso, and macro level of analysis. And arguably, for those of us who are invested in working through intersectionality and the muck that it creates, it produces a more accurate knowledge and evidence about how people actually live their lives. So, to give you a concrete example of the difference it's made in a field that I emerge from, but am now highly critical of, is women's health. The question that's often been raised in recent critiques is what has been left out of researchers' analyses because of the conceptualizations that have been used in the field of women's health. Well, there are growing critiques about the systemic exclusion and marginalization of the experiences of different groups of women, and by default, focusing on the most privileged women, that is white, middle class, able-bodied, and heterosexual women. That the organizing around the category of women in women's health has resulted in the exclusion of women who are construed as or constructed as different from whatever it is that unites the particular subgroup, who are really unaware and unreflective of their class, race, heterosexual, national, able-bodied position, and the privilege that these confer. So within the broad category of women, within the women's health field, intersectionality reveals that it is possible to be both privileged and marginalized, that social relations are so complex that nearly everyone is privileged in some ways and disadvantaged in others, and it doesn't mean that everyone is equally advantaged or disadvantaged. In any case, the take-home message within the field now is that women's health needs to better integrate the various and intersecting factors that influence health among women, and that is absolutely a key prerequisite to any kind of comprehensive understanding of women's health. So now I'm going to shift gears and offer a number of questions for consideration in relation to gay men's health. The first question I think that it's important to think about from an intersectionality perspective is, how is gay men's health currently conceptualized and defined? What are the implications if the focus is primarily on gay men as a homogeneous group? Does the struggle focus on the experiences of upper class, white men, marginalizing less privileged queer people? Is there any kind of race or class bias within the movement, within conceptualizations of gay men's health? What are the implications of focusing primarily on sexuality or sexual orientation, or alternatively heterosexism or homophobia, to the exclusion of others? What are the implications of only considering issues of gender in addition to sexuality, using a kind of additive approach that prioritizes sexuality and gender? Moreover, what are the relevant axes for understanding differently situated gay men and their health needs and experiences? And this is really an issue of power. And I quote from Crenshaw's work in 1992. And Crenshaw is considered to be the theorist who really put intersectionality on the map in contemporary times. And she writes, "The struggle over which differences to consider is one of power. Who determines whether and which intersectional differences will be addressed in research and policy formulations?" And I think this is really important to keep in mind, is that determining what is considered, who is included, is an issue of power. And then another important question, a final question, is how can gay men refrain from the participation in the oppression Olympics. That is positioning themselves vis-a-vis other groups that are seeking resources, support in working towards a better understanding of their health needs. How is it possible to identify strategic coalitions for advancing needs and concerns? And intersectionality does talk a lot about the fact that these kinds of strategic coalitions can be developed, can be forged by expanding on the different axes that are considered within any kind of movement. And what might be the implications of intersectionality in terms of gay men's health? Well, perhaps raising a number of important considerations and realities. Thinking about who are the winners and who are the losers in how gay men's health is currently conceptualized. Underscoring the fact that gay men are not a homogeneous group, that complexities cannot be afterthoughts, but must be interwoven into the design of research, policy, and practices, and that there are many factors that are at play: geography, race, ethnicity, ability, age, sexuality, religion, immigration, status. And I think that also it's important to note that gay men's health is also structured along a range of axes other than the ones that are typically considered within intersectionality frameworks. And these include things such as HIV status, comorbid health issues, relationship status, and life stage, including critical transitions. And the power of intersectionality in this context is the fact that there's a need to look at both individual social locations, interpersonal relations, but also the intersection of social structures. It may draw attention to the often unacknowledged heterogeneity among gay men and their communities, and may also encourage strategic coalition building among other groups experiencing a range of health inequities. And in conclusion, just a few points of highlight. Intersectionality illuminates that human lives are embedded in multiple contexts, historical, cumulative, and interlocking. It shows how differently socially situated perspectives will not only provide more precise information, but also yield greater insights into systems of marginalization and oppression. And intersectionality assists policymakers and service providers alike to deliver more effective, more efficient programs and services that better meet the needs of those individuals and groups most disadvantaged by social inequities. And finally, a caveat: intersectionality is still very much under development in both health research and policy, but for many researchers and policymakers and advocates and community-based workers, it is a way of the future. And I think that this is also what makes it so very exciting in terms of thinking about intersectionality in the context of gay men's health. As I was preparing for the talk, I did a very cursory search and saw that there's very little written about the relationship. And I think that applications of intersectionality to gay men's health have the potential. It's not just a one-way street. It's not that we're just saying, okay, intersectionality can do this and this and this in terms of gay men's health. But I think if we start with some applications in the context of gay men's health, that those findings, the process of application, has the potential in turn to inform the theory of intersectionality, to inform its further development, and really demonstrate the way in which the theory may need to be adjusted and reconceived for future discussions of health inequities and health disparities. Thank you.